Right, so finally, I have included some researches I found um, in the literature and that are really interesting because they show how everything we talk about in this lecture is applied to the clinical practice. So the first one is this one, failure rate of inferior alveolar nerve block among dental students and interns. So the inferior alveolar nerve block is very it's a very common technique used for local anesthesia, but the failure can be high, reaching between 15 to 20%. And the failures include technical errors, infection, inflammation, previous surgery, and psychological causes, for example, anxiety or apprehension. A poor technique has been referred as the most common reason for the failure, and this may be related to inadequate mouth opening, incorrect needle placement, so too anterior or too posterior, failure to give enough time for the anesthesia to work. The standard inferior alveolar nerve block procedure is a direct technique where the thumb is placed at the deepest concavity of the anterior surface of the ramus at and the site of the injection is located midway between the midpoint of the thumb and the pterygomandibular raphe. Then the needle is advanced between 15 to 25 millimeters parallel to the contralateral premolars until there is bone contact, so until the needle touch the bone. The most common complications in this case were facial paralysis, hematoma, and trismus. So facial paralysis when the needle is placed too posteriorly and we inject the solution in the parotid gland. So as the facial nerve is running within the parotid, we can block this nerve, but this is like transitory. And trismus means that the patient won't be able to open the mouth because of like a hyper contraction of the muscles, and this will be painful. So when this happens is when, for example, we like touch with the needle the medial pterygoid, and therefore there will be like a contraction of these muscles, and the like they will react, and it will be painful for them to open the mouth later. So how to improve this technique and avoid the possibilities for the failure? So we need to know alternatives for the inferior alveolar nerve blocks, such as the GO gates and the Akinosi techniques. If there is an infection, for example, have an adequate knowledge of the anatomical landmarks, train the students on how to select the most appropriate alternative technique, increase supervision and training of the various techniques, emphasize that aspiration is mandatory before any anesthetic technique because we can put the solution within a blood vessel. Now, the second article I want to show is this one, anesthetic efficacy of an inferior alveolar nerve block in soft tissue and correlation between soft tissue and pulpal anesthesia. So the inferior alveolar nerve is composed of several nerve fascicles. Each of which innervate different areas. The most common patterns of nerve fascicle innervation are the following. Molars, premolars, incisors, and canine, and the buccal mucosa anterior to the mental foramen, and skin of the lower lip and chin by the mental nerve. So the inferior alveolar nerve block should anesthetize these areas, but the anesthetic success rates have been reported to be variable, and this study proposed that it will depend on the fascicle. So the lingual mucosa of the mandible and the buccal mucosa posterior to the mental foramen are supplied by the lingual nerve and the buccal nerve respectively. Therefore, it is not possible to predict if they will be anesthetized by an inferior alveolar nerve block. But the lingual mucosa is usually anesthetized with an inferior alveolar nerve block because of the proximity of the lingual nerve to the site of injection of the inferior alveolar nerve block, as we have seen before in the diagram where we had the lingual nerve anterior to the inferior alveolar nerve. So it is aimed to achieve the anesthesia of the lingual nerve after an inferior alveolar nerve, and this is achieved with a change of the angulation of the needle. And there is some degrees of anesthesia in the buccal mucosa at the molar region, but usually a separate anesthesia is performed for anesthetizing this area because the success rate is this can widely vary between 30 to 86%. Most patients report lip numbness between 15 to 20 minutes after the inferior alveolar nerve block, and soft tissues anesthesia is easier to confirm than the pulp anesthesia. In this study, they were investigating if the inferior alveolar nerve block can anesthetize not just the areas innervated by the inferior alveolar nerve, but also lingual mucosa of the mandible and the buccal mucosa posterior to the mental foramen. So they tested 4 sites of soft tissue: the corner of the lower lip vermilion border, the buccal attached gingiva of the lateral incisor, the buccal attached gingiva between the first molar and the second molar, and the lingual gingiva between the first and second premolars. And they realized that the more fascicles in a region, the more difficult it may become to anesthetize that region. So they have concluded that the anesthetic success rates have varied depending on the fascicle, and the highest success rate was found in the lingual gingiva between first and second premolars, which indicates that the clinicians need to consider not doing an additional nerve block, but this is only in some patients. So I have chosen these papers to show you, first of all, how important it is to know the anatomy for a daily basic technique, but there is also variation between patients. So as long as you know the anatomy, which areas you're blocking and working with responsibility, you will be definitely be more than fine. So here there is a little bit of recommended uh, reading, just in case if you would like to read more about this topic, but this is not mandatory at all. So thank you very much. And please, if there is any question, feel free to write me. And I hope you have enjoyed this lecture.